All right, let's jump right in. Today, we're doing a high-yield review of gastric malignancies. We're going to cover the absolute must-know concepts that you're going to see on the wards and, yes, on your exams.
So let's kick things off with a scenario you will absolutely encounter. Your patient comes in with this nagging pain in the pit of their stomach, and they tell you they get full after just a couple bites of food. Right away, alarm bells should be ringing. Gastric malignancy has to be high on your list, but which one? Let's figure it out.
Here's how we're going to tackle this. First, we'll go from the patient's symptoms to the endoscopy. Then we'll dive deep into the most common culprit, gastric adenocarcinoma. After that, we'll talk about the other big one, lymphoma. Then we'll cover how to stage these cancers, and finally, we'll wrap it all up with some can't-miss clinical pearls. Let's do it. Okay, Section 1, from symptom to scope. So you've heard those alarm symptoms. The next absolutely critical step is an upper endoscopy, an EGD. And we're not just going in to take a peek. We're on a mission to get tissue, because that's the only way to get a real diagnosis.
And here's something that's super important to get right. You can't just biopsy whatever looks weird. There's a system. This 5-biopsy protocol is key. You take 2 from the antrum, 1 from the incisura, and 2 from the body. Why so specific? Because this systematic mapping is the best way to find intestinal metaplasia, a huge cancer risk factor, and to track down H. pylori. So let's move on. You've got your biopsies, you send them to path, and the report comes back adenocarcinoma. This is the big one, folks. It's the vast majority of all gastric cancers. But here's the twist. Not all adenocarcinomas are created equal. Understanding the different types is absolutely essential for figuring out prognosis and treatment.
The system you have to know is the Lorne classification. It basically splits gastric adenocarcinoma into 2 main flavors, intestinal and diffuse. You should really think of these as 2 completely different diseases. They look different, they act different, and they're driven by different things at the molecular level. And this isn't just for the textbooks, right? This classification has huge real-world implications for your patients.
And this slide just lays out the differences so clearly. On one side, you've got the intestinal type. This is your classic gastric cancer. It tends to happen in older folks. It forms a lumpy, polyp-like mass, usually in the lower part of the stomach, and it's tightly linked to H. pylori. Then you have the diffuse type. This one's way sneakier. It hits younger patients, and it doesn't form a nice, neat mass. Instead, it causes this diffuse, leathery thickening of the stomach wall. We call it linitis plastica, and it's tied to a specific genetic mutation in a gene called CDH1.
That CDH1 gene brings us to a really high-stakes diagnosis: hereditary diffuse gastric cancer. If you have a young patient, especially with that diffuse type, you have to have this on your radar. It's an inherited disorder, and the lifetime risk for diffuse gastric cancer is sky high. So high that the recommendation for people who carry the mutation is to have their entire stomach removed prophylactically. And it doesn't stop there. Women with this mutation also have a much higher risk of lobular breast cancer. This is one of those diagnoses that completely changes everything.
Okay, let's switch gears completely. Let's talk about the other major gastric cancer you need to know about, lymphoma. Now, it's not nearly as common as adenocarcinoma, but believe it or not, the stomach is the #1 spot for lymphomas that start outside of the lymph nodes. So it absolutely has to be in your differential.
Just to put it in perspective, we're talking less than 5% of all primary stomach cancers. So yeah, adenocarcinoma is the main event, but you'll see lymphoma. And it's crucial to remember that it's a totally different beast with a totally different playbook.
And when it comes to gastric lymphoma, there are 2 main subtypes you need to know. There's diffuse large B-cell lymphoma, and then there's maltoma. And here it is, the absolute killer clinical pearl you have to take away. Maltoma is often driven by H. pylori infection. This means in many early-stage cases, you can actually treat the cancer simply by getting rid of the H. pylori with antibiotics. How wild is that? You got to remember that one.
All right, Section 4, you've got your diagnosis, whether it's adenocarcinoma or lymphoma. What's next? Staging. Staging is everything. I mean it. It's the step that tells you how far the disease has spread, it predicts the patient's prognosis, and it dictates your entire game plan for treatment.
And look, staging isn't just about slapping a number on a chart. It is the roadmap that tells us everything, whether the patient is a candidate for surgery or if they need chemo or radiation or some combination. It really is the cornerstone of all cancer care.
So for gastric lymphomas, we use what's called the Lugano staging system.
Stage 1 means the cancer is just in the stomach wall. Stage 2 means it's spread out into the abdomen, maybe to some lymph nodes. And Stage 4 means it's disseminated. It's in the bone marrow, the liver, or somewhere above the diaphragm. Now, you might be looking at this and thinking, where's Stage 3? And you'd be right. There is no Stage 3 in the Lugano system for GI lymphomas. That is a classic gotcha factoid you need to know.
Okay, let's bring it all home. Section 5, the high-yield clinical pearls. If you've been zoning out, this is the time to tune back in. This is the stuff you absolutely need to have locked and loaded for rounds and for your exams.
So if you remember nothing else, remember these 4 things. 1. Adenocarcinoma has 2 main faces, the intestinal type tied to H. pylori and the diffuse type tied to CDH1. 2. See a young patient with diffuse gastric cancer? Think about the hereditary syndrome and the potential need for a prophylactic gastrectomy. 3. The malt lymphoma pearl. Treat the H. pylori and you might just cure the cancer. And 4. Staging is king. For GI lymphomas, you use the Lugano system. Got it?
We've covered the fundamentals, but this field is constantly changing. We talked about the molecular differences between intestinal and diffuse types, but that's really just scratching the surface. So the big question looking forward is this. As we get better and better at understanding the specific molecular drivers of each tumor, how are we going to move beyond these broad categories to create truly personalized therapies for every single patient? That's the challenge for you all. Thanks for tuning in.